Welcome to the Listen Up podcast, where we explore hearing loss, communication, connections, and health.
Hey everybody, Dr. Mark Sims here. I'm the host of the Listen Up podcast, where I feature top leaders in hearing healthcare. This episode is brought to you by Listen Up Hearing Center. I help patients to effectively treat their hearing loss so that they can connect better with their friends and family and remain independent. The reason I'm so passionate about helping patients with hearing loss is because I lost my brother Robbie twice. First from his hearing loss from radiation to his brain tumor, and then again when he passed away. I only care for ears. I'm the E of ENT. I've performed over 10,000 ear surgeries over the past 20 years and taken care of many more people with hearing loss since. I'm the founder of Listen Up Hearing Center. I'm the author of a book called Listen Up, A Physician's Guide to Effectively Treating Your Hearing Loss. If you want to learn more about that, go to listenuphearing.com. Today, I have a great guest, a mentor of mine. It's Dr. Bruce Gantz. He's a professor of otolaryngology and neurosurgery at University of Iowa, and he's been practicing for over 40 years. He was recently the chairman and stepped down and passed the baton to my good friend Marlon Hansen. His areas of expertise include hearing loss, acoustic neuroma, and Bell's palsy. He's one of the world's top cochlear implant surgeons, and he's a leader and pioneer in cochlear implantation and a leader in electroacoustic hearing. My exposure to him is one of the first trials for electroacoustic hearing I did was a trial site for Dr. Gantz back in 2004, 2005. Dr. Gantz, Bruce, thanks for coming on the podcast. Beautiful backdrop of your lovely home.
Well, Mark, thank you very much for having me on.
Oh, my pleasure. So as I know, and the listeners will learn that you've been kind of you have been the guy pushing kind of electroacoustic hearing. That's kind of an insider phrase that we use, or hybrid hearing. Can you just for the listeners describe the concept or what we're looking to do and why it's something that people should know about and think about?
Well, thank you, Mark. So, when we started implantation, this was in the late 70s, early 80s, we were implanting people that were so deaf they couldn't even hear themselves speak. And we were really excited when all of a sudden they had an aid to lip reading. Mm-hmm. And so these were single channel devices. We got involved in multi-channel implants early on through some serendipitous experiences. First, I was in Vienna, Austria, and met the Hochmeyers, which is Medel company now. And back when I was doing a fellowship in Zurich, Switzerland in the early 1980s, 1982, I actually brought a couple of their implants, which were supposed to be 4-channel. So it was the first really multi-channel I had some experience with. And I brought them in my suitcase. This was before the FDA was involved. And I actually sterilized them and put them in patients. They worked wonderfully as single-channel devices. They never multi-channel. Then about a year later, I was contacted by Cochlear Corporation, which was not cochlear at the time. It was called Nucleus. And they wanted me to get involved with their multi-channel. And so I went to Australia, learned from Graham Clark about the implant, came back, and we were the first people to actually implant a multi-channel implant outside of Australia in March of 1983.
That's awesome.
There's been a long experience. So that's sort of my previous experience. And then as we went along in the 1990s, we found that patients that had a little more residual hearing did a little bit better with their implant. And so we had a concept that maybe if we tried to preserve some residual hearing, like Bill House did when he tried to implant some people with tinnitus with 6-millimeter electrodes, they were actually able to preserve some residual hearing. Right. So we took that concept one step further and designed a device with Cochlear Corporation and actually put in the first device in 1999. We put 3 of them in. We preserved all the hearing, but it was too short. It was too high frequency. There was too much dead region in the base. And these patients had been hearing loss so long. We then moved it to 10 millimeters. And lo and behold, these people got an enhancement in their word understanding significantly over just electric only. And there was about a 20% improvement in their word understanding when we had the electric acoustic together using low frequency acoustic hearing in combination with electric hearing for high frequency. And lo and behold, they got a lot better. Moving forward, we found that, again, serendipitously, these people heard extremely much better than people with electric hearing in noise, and much better than hearing aids. And so there were two advantages of electroacoustic hearing. Was one, it improved their overall performance in quiet, and number two, it was significantly better in noise. So from that, we evolved from a 10 millimeter device. We used 16 millimeters. Now we're using 20 millimeters. But the key is to try and get somebody that has low frequency residual hearing that is aidable, and then preserve that hearing and let them then use this in combination. And fortunately, this has been a real benefit for the people that we've been able to do this. It's been slow going. I guess one of the reasons is that you have to be able to select patients with residual hearing.
Right.
And it's difficult to find those. It was in the past. It's becoming easier as we are expanding our criteria for cochlear implants, and people can now qualify for a cochlear implant if they have 60% understanding in sentences or worse. And a majority of those people have some low frequency hearing. And so it's really
they're sitting in the dispensing audiology's offices, right?
Right. And I will tell you, Mark, that if you look across time from about 2000 to 2023, our electric only patients, the results in 1 year has not changed in 25 years.
But they're about the same, right?
It's about 60 or about 57 to 60% word understanding. If you preserve residual hearing, you're up into the high 70s or 80% in quiet. And if you're in noise, it's significantly better. So in noise, if you do a sentence test in noise at a signal to noise ratio of 5 dB, that's a little complicated maybe for your audience, but meaning the noise is at about 5 decibels louder than the sound, that the words that are coming in. That's a really hard test.
Right.
And patients with single channel implants get about 30% correct in sentences. And our patients with electroacoustic hearing are averaging this 70% with acoustic plus electric in a signal to noise ratio of 5 dB. Huge benefit.
Yeah. And so what percentage of in your practice would you say are going into electroacoustic hearing? I mean, it just happens to be who comes to you, obviously. So it's just kind of the University of Iowa implant pool. How often are you seeing that?
Actually, in our population, we've got residual hearing significant to try and preserve between 35 and 40% of the time. And we think that if you have better than 60 decibels of low frequency hearing at 125 hertz, 250 hertz, and 500 hertz, that pure tone average, if it's better than 60, you've got a significant benefit. You've got a significant chance of saving residual hearing.
So is that because that's within the functional parameters of a hearing aid, or is it because you think that's more predictive of saving hearing? Do you see what I'm saying?
Yeah. So let's talk about functional hearing.
Right.
Functional hearing means the ability to amplify that acoustic signal enough with a hearing aid that you get some word understanding.
Right.
When you get to be 80 to 85 decibels in those low frequencies, you can power the heck out of that ear and it's not going to work. You're not going to understand anything. So we know that when we put the implant in, we can drop 10 to 15 decibels just by putting the electrode in the inner ear and the inhibition of the traveling wave, probably. So if you start at 60 and you go down to 75, you're still amplifiable.
Right.
If you start at 40 or 30, you're even better chance of saving it. And so, we've got some patients that have 20 to 30 decibel low frequency hearing that we implant all the time. And we've got a pretty good hearing preservation rate. If we use the right electrode, we're between 75 and 80% preservation of hearing that is amplifiable.
And I assume that that's to some extent the justification or the rationale for the development of the insertion robot or tool that's been developed in your department as well, correct?
Yeah, that was Dr. Hansen and his team that developed a robot to put in the device at 0.1 millimeter per second. You can hardly see it move. And what they showed that when you put it in manually, our hand is just not that good. I mean, I've done 4,000 implants, and I can tell you, I'm not that good. I'm not as good as the robot. And so they did some research demonstrating that even with slow manual insertion, you jerk and you cause increasing in
Fluid displacement,
and it causes a change in the fluid in the inner ear, and it causes injury. And so the robot that goes in slowly, now we just finished a group of 15 patients with the robot, and our preservation rate was 93% in that group so far at 6 months. So I don't know if it's going to continue, but that's pretty darn good if we can do that.
So just as a technical question that I want, with your trial back in the day when I did the very short with you and your trial, Dr. Gantz, you secured the electrode with a stitch. Are you still doing that?
I certainly am.
Okay. So that was flipping or whipping around, correct?
Yeah. And so even with the robot in place, we take the robot off holding the electrode in the electrode has gone through a suture, and then we tighten that before we do anything else and tie it in place so that you're not transmitting pressure into the inner ear and more trauma.
Especially when you're coiling the excess electrode into the mastoid, correct?
There's all these little issues that make a difference. And trying to eliminate that, the more we do, the better we're going to be able to do for people. Because, in my mind, you have one chance to save this residual hearing. And if you lose it, then that person is never going to do quite as well in quiet, and they're not going to do as well in noise. And, as we continue to expand the criteria, if you're not careful, we may make some people worse if you're not paying attention to.
I disagree with you. As we get more and more come up the audiogram, as you will, closer with less volume and discrimination, you're absolutely right that that if they lose their hearing, will they bounce back to a functional level that's greater than their pre-operative hearing? And I think, unfortunately, there are some patients that are being seen that don't actually do better post-operatively than they did pre-operatively.
Exactly. And so, it's really incumbent on the surgical community to address this and adopt these issues. And we can show you from some of our research that when you preserve residual hearing, you preserve more of the natural, actually central auditory processing that goes on in the brain. And we have
because of direct connections, or is there degeneration of the neurons with the damage to the ganglia? I mean,
well, I will tell you that this gets a little technical, so I don't know how far you want me to go into this, but there are uh, we do EEG measures
Right.
of the activity.
Sure.
And we know that when sound is presented to the lateral temporal gyrus,
Mhm.
that is a series of responses that you get from that EEG. And there is the early peaks are at a 0.1 to 0.2 milliseconds after the onset of the sound.
Right.
And if you have acoustic plus electric hearing, your onset is almost normal within that 0.1 to 0.2 milliseconds. If you have electric only, your onset is about 0.6 milliseconds. So there's a delay in the brain activity. And what happens is that we see in the frontal region of the brain, it causes more confusion and
Because
more
of the
activity.
asynchronous nature of the information with the lip reading and the other prompts or something.
It's a complex issue, but the brain has more trouble figuring out the word. And in fact, we can do eye tracking measures where we give people a paradigm of four different pictures. And we say something like sandal. And there may be a picture of a sandal, there may be a candle, there may be something else, and something else. And so as the word is being said over, 100 milliseconds, the eyes are going to these four pictures until they recognize the word, and then it goes right up to that picture. And that's called an eye tracking experiment. That's very classic and
So it shows comprehension, essentially. It's a way to measure comprehension with your eyes.
You got it. It's how fast the brain recognizes that word. And so you measure that slope of how fast the eye gets to that point.
Sure.
And if you have electric hearing only, there's a 75 to 100 millisecond delay for each word that is said.
So that adds up over a sentence.
Exactly. And so if you have electric plus acoustic information, it slopes almost normal. So there are central mechanisms within the brain that recognize the word quicker because you've got some of that low frequency information that's so important to help you recognize a word. And so that's why, in my mind and our research, and I'm so passionate about the fact that we've got to preserve residual hearing.
All right. So let me ask you a question. What if you have equal hearing on both sides, implant one side and aid the other? How does that work as compared to, you see what I'm saying? Acoustic on one side, electric on the other.
It's not
as good as acoustic and electric in one ear.
Not necessarily. So because you've got a normal hearing ear on the other side. Okay.
No. I'm talking about both ears are, so in the Medicare,
I see.
You have to pick an ear, right? So before all this, Dr. Gantz, if I saw somebody who had what you're talking about, residual low slope, and then a deep diving high frequency, some of them would opt for a regular electrode because they wanted the high tone hearing on the cochlear implant side. So this is like a low tone on the non-implanted side, high tone on the electric side. It's using two ears. Obviously, we know binaural benefit, but that's where I'm thinking.
Okay, so that's called bimodal.
Right.
Okay. And so we have like 147 patients with bimodal hearing. And their bimodal hearing is still about 10 to 12% below
EAS.
the EAS. So the EAS is better when you have the acoustic in both ears.
Right.
And there's another advantage that we're just recognizing in some of our central auditory processing experiments. So In-Young Choi is one of the people that works with us. He's a PhD in speech and hearing, and he's the one that does the EEG work.
Sure.
So he presents us a tone and then there's a short onset, and then there's the word, okay, that happens. So when you have acoustic plus electric compared to electric only, when you turn on that tone, the electric only ear responds with a much greater amplitude. And the acoustic plus electric group is suppressed. So there's some central suppression with the acoustic hearing that helps to depress the response to that initial turn on of the.
Some sort of natural feedback that you lose with electric hearing.
Exactly. And that's something we're just beginning to understand and just beginning to explore. But that acoustic hearing is dear. You cannot do anything better.
You're just reaffirming that in an ideal world, the acoustic hearing is better than the electric hearing, right? I mean, obviously, we're implanting patients that have lost it, but just as a word to the listeners, it's much better for you to preserve it. In other words, protect your hearing and don't lose it, as compared to asking us to give it back.
Exactly. And if you have some residual hearing and you're having trouble in noise, which is the biggest problem for people with hearing aids, that if you can get to someone that has some experience and able to use and preserve that low frequency hearing, it's a huge benefit.
Sure. If you're going to get a cochlear implant. Yeah, I agree 100%.
And so you have to make a decision whether or not you want to live in an environment with a hearing aid and poor word understanding, and then on top of it, hearing poor in noise, or do you want a chance possibly losing some of that residual hearing? And I will tell you, Mark, that we're just looked at about 28 patients with these shorter electrodes, the 10 millimeters in the, which were the hybrid S, the trial you were in, the S8.
Right.
Okay. That group versus the L24s. So the L24s were 16 millimeters. The S8 population today is still our better hearing preservation at 79% of people up to over 15 years using the acoustic plus electric. So now we've had, I think, 7 patients of that original 80 lost significant hearing that we've been able to track from our center.
Right.
And we then just, when you lose that residual hearing, you just increase the frequency range on those 10 electrodes. So you expand it. And those patients then become bimodal.
Right.
Of those 7 patients that have lost the acoustic plus electric, they are at the same level of performance as the bimodal group of that 146 that I told you with a standard electrode. So we have not had to change any electrodes of those short. Now we did a number of, we had about 20 of the L24s that failed.
Mm-hmm.
And again, the majority of those did very well bimodal, similar to the bimodal long electrode patients. We did change out 5 devices. And when we changed them out, 1 got better, who didn't get anything with the short electrode in the first place, or the 16 millimeter electrode in the first place. The other 3 didn't get much better, but got slightly better, and 1 got a little worse when we put in a longer electrode. So it's a real, is that the answer? I'm not certain. It may be.
It's hard because there's scar envelopes. There's all sorts of things that are, that's why you're saying the first shot is the best shot, because that is the shot.
And also it's probably the neural environment initially.
Right.
Okay.
Well, that's the thing. Stratifying these patients out to the ones that actually, I mean, that's probably the hardest thing, is if you had all of the factors that determine success, we'd be much better at having success, because we pick and do the ones that were actually, predisposed to great success.
Right. So there's a lot to it, but I think that's going to be the trend in the future. Because
go ahead. I'm sorry.
We're going to continue to expand our criteria. we're going to get better at preserving residual hearing. And at some point, these individuals that are struggling are going to have to make a decision whether or not they want to go to the next level. And I think they probably will.
Yeah, I think a couple of challenges. One is cochlear implant candidates really can't intellectualize what we're talking about. So that I think is a huge thing. They all just want to hear better,
Right.
and that becomes really difficult. The other thing I was interested, I was talking to my cochlear implant team just last week about there is a shortage of research and presentations of who not to implant or who not to do these things to. Right? We oftentimes do acts of commission rather than omission. But I think the nuance will be who we don't do some of these things on, not who we do some of these things on.
You're exactly right. I'm right with you. And I can tell you that we did a group of marginal patients for hybrids with the L24s, and we quit doing it because we said, okay, how about some of these people that were worse than 60 in these pretty low frequencies, but better than 80? You have to have more reserve than that.
You might as well have done a full length and gone to pure electric stimulation for those, right? Yeah, and so that's the hardest thing. It's not as quick. I mean, I think some of our listeners and patients believe it's all formulaic, and it's not. It's still an evolving thing, right? Even backing up, I have struggles getting some patients to understand what they're getting themselves into, let alone some of these more highly nuanced things that you and I are talking about today.
I completely agree, and I'm just hopeful that our whole community will continue to embrace this rather than just jamming long electrodes in patients and not giving them a chance.
But I mean, I can even tell you, I agree with you. But even the surgeries that you introduced with the attempts to preserve hearing themselves really led to just a change of all. I mean, when I think about what I watched at the beginning of my career, where we opened up the round window and you could see down the basal turn of the cochlea because you're taking all the fluid out and put the electrode in, as compared to now where we're microscopically piercing the round window membrane and slowly advancing a thing. I mean, we've come a long way just in terms of, the elegance of insertion regardless.
You're exactly right. You're right. And, I think we're going to get better. The other strategy we use a lot now is ECOG, electrocochleography. So, unfortunately, when you're putting an implant in, you have no haptic feel for where you are. And so with the monitoring with ECOG, now we can do a whole nerve action potential and measure that wave 1 through the implant. And as we're sliding it in, we can see the change in the response. And you can back up the electrode. If you're going slow, like we do with the robot, you can reverse it, move it a little bit, and go back in. And I think that really does help us to monitor and watch what's going on in the inner ear. So the robot, the ECOG, there'll be other strategies that'll come about that'll make this a safer environment for all.
Yeah, it's amazing because I think back to how when I first started in the late 90s, how we really were. I mean, not that it's not a concern now, but it was much more often that we didn't have a totally patent cochlea. There were anatomical changes, ossification and all that. Like they still happen, but we're going into much healthier cochlears where we can do things like reverse it, steer it, all of these. I mean, back then, sometimes we were, again, just happy to get it in, if you will. And so, and it's true, right? And a lot of, we've got,
listen, I contributed to that because
we needed to get it in.
One of the things that I did, though, was in the obstructed cochlea is drill a part of it away and then get in as many electrodes as you could after that. And so I had this concept that, well, maybe the cochlea isn't that important, but I changed my philosophy over time.
Well, but that
And
still might be the case for that particular instance, though. If you've got to drill it out, you've got to drill it out. It's just we don't see them as often, I think.
and it works. It's just like now. The other day on Thursday, we put an implant in a patient with NF2 that had been irradiated,
Right.
and there was tumor in the cochlea. We took it out, put the electrode in, and it works.
That's amazing. Yeah, I mean, just when I was doing my fellowship, I was involved in a lot, maybe 40 or 50 ABIs because it was right when they were getting approved. And it's amazing how it was a great answer then, but the cochlea and the distribution of nerves in the cochlea is just so far superior to the nucleus in the brainstem.
Exactly. And so, we're doing all we can now, and we're approaching tumors differently.
Because you want to preserve the cochlear nerve.
Yeah, and we want to preserve the cochlear nerve. We'll do a translabyrinthine approach, take out the tumor, preserve the cochlear nerve, and then come back and put an implant in. And that works about 70% of the time.
Yeah.
So it's getting, we're changing how we approach a lot of things that we thought we couldn't do in the past.
No, well, I mean, it is the practice of medicine. People don't like that concept, but we are trying to figure out and do what's best with the current information that we have. And I really, I had Marlon on too, and guys are doing this day to day, getting the data, analyzing the data, creating new knowledge. I really admire that dedication to that, especially, I mean, University of Iowa has always been on the cutting edge of this for probably its whole existence, right?
Well, I'll have to brag here a little bit. We just got refunded for the 8th time, our 8th 5-year competitive renewal for our P50 grant, which is the University of Iowa Cochlear Implant Clinical Research Center. And so that's been going on now. It'll go on to 2028 so far, 43 years of continuous. Right. And without that support from the National Institutes of Health, we wouldn't be able to make the strides and do the kind of research that we do. And that's an institution like us needs to do that.
I agree. That's your role in the community. And it's one of the roles of federal government funding research. And it's one of the good outcomes, right? I mean, you guys are making new knowledge and giving us better ways to practice the art and science of medicine, which is kind of what we're all here for, I think.
I hope so.
Yeah, me too. And I very much appreciate your contributions. So where do you see it, Dr. Gantz, like 20 years from now? Where do you see all this? I mean,
I think
look into your crystal ball, and you know what? Obviously, we're not going to hold you to fidelity to it, but where do you see this all going?
I think the majority of people over the next 20 years that are having difficulty in noise are going to come forward faster, and we're going to be better at preserving hearing. I think we're going to get to 90 to 95% hearing preservation by selecting the right people. And then I'm hopeful that they'll have a lifetime of hearing as long as you preserve that low frequency. And it's interesting as you look at audiograms of people with presbycusis or even other genetic disorders, very slowly does the low frequency hearing go down.
Yeah, it's pretty resilient.
It's about 1 dB per year. And so you have to go 70 years before you're going to lose that low frequency hearing, most likely. So I think we're going to implant people younger. I think this is going to be a strategy that is going to impact cognitive ability of the individual and their ability to be out there in society, and they're not going to withdraw and have all of this cognitive decline. So I think hearing healthcare is becoming more and more of a central focus for human health, and we have not paid that much attention to it. The report from the Lancet Commission showed that 9% of the variability of cognitive decline can be attributed to hearing loss and be prevented. And
No, it's amazing.
That's one of the more, it is the largest portion of the cause of that cognitive decline. That
It's the
we
most modifiable factor that they report. It's the thing you do the most.
And so that's real. And I think that is going to impact where we are in the auditory hearing healthcare in the future.
Yeah.
And I think that we're going to get better at remote care of these individuals. They're not going to have to keep coming back to the center. We're going to remotely program them. We're going to probably, the patient themselves may be able to tweak it a little bit. And all of those things are going to help because we will not survive. We don't have enough resources to keep expanding the population and the little bit of reimbursement we get out of that. It's not going to work. And so we have to think about out of the box solutions.
Yeah, I agree. My one comment about the kind of thing is I think we have to get out of device-oriented language. So what I mean by that is, the primary care tells the patient, go get hearing aids, or somebody says you should get a cochlear implant. And it's kind of interesting that that's a prescriptive concept. The real answer should be, you don't hear as well as perhaps you want or you should. Go get it evaluated. And then, because I think people underestimate the complexity of coming to the conclusion of the intervention. It'd be kind of like saying, well, you have coronary artery disease. Go to the cardiothoracic surgeon and get quadruple bypass. Well, there's a huge diagnostic underlay that leads to that conclusion of therapy. And I think there's something in our vernacular where we are device conclusive. I think, frankly, it has to do with the industry wanting us to talk about their particular solution, but we really need to get into the language of talking about treating your hearing loss. And then that's where the otologist lands, right? What is the right modality and the right technology to actually treat your hearing loss? And it's not as complete. I mean, look at the conversation we're having. Is it a cochlear implant? Is it an electric acoustic hearing? Is it your hearing aids aren't programmed right? I mean, there's just so many things. I see people with 80 dB hearing losses with open domes.
Yeah.
It has nothing to do with a cochlear implant. It has a lot to do with their so that whole concept. The concept of what treating your hearing loss rather than a technological conclusion.
Right. And I think that it's going to get easier. I mean, hearing is not difficult to measure over the telephone. And
no, you're right. I think the other fault that our system has is this concept of subjective assessment of people's hearing. I'm sure you've seen them too, Dr. Gantz, where there are people come in who have a 70 dB loss and they look at you and say, I don't have any hearing loss. And there are other people who come in with a 20 dB loss and say, I'm totally debilitated. I can't hear anything. And so subjective assessment of one's hearing is kind of crazy when you think it's like, you don't know what you don't hear. So how do you assess what you don't hear? And so it's an objectively measurable thing. And all of these indexes and handicaps and surveys, they don't correlate with symptoms. It's really a measurable, objectively performative field that we're in. And we have to get away from, they're not motivated to do something about their hearing loss because they don't perceive it. Well, that doesn't matter. They have a hearing loss. It needs to be treated. That's the answer. It's a medical model, not a social model.
Sort of like hypertension.
Correct. Exactly. I use that analogy all the time. Just because you don't feel bad doesn't mean you shouldn't get your blood pressure treated.
I mean, at some point, your blood pressure does cause you problems.
Correct.
But for years, you can be asymptomatic and have terrible blood pressure.
Correct.
And so, I think it's the same thing with hearing loss. And there's this stigma that you're getting old if you have a hearing aid. And
I think people know you're old when you don't have a hearing aid, to be honest with you. When you're old, you can't hear. That's the answer.
Yeah.
Well, this has been great. I very much appreciate your time giving it to us, and it's good to talk to you. And I just want to let you know I appreciate your mentorship over the years. It's been very valuable to me.
Well, Mark, you're a key player here, and your patients must love you for the care you're giving them, and the interest you have in this whole issue. So please keep it up.
Yeah, I approach it a little bit more from an access point of view, which is kind of my interest, making this accessible to people. That's kind of where but giving people the information like you provide is wonderful.
If you have questions, call us, or if your audience wants to call us, they can get in touch with our office, and you probably have that information.
Yeah, well, tell them
on
it's
this.
the University of Iowa Department of Otolaryngology website, correct?
And the office telephone for Dr. Hansen and myself is 319-33 or 353 2173.
There you go.
2173.
So,
and the area 319.
Yep, that's the Iowa area code, I suspect.
Yes.
So, well, again, thank you so much.
We have sunshine like Arizona today.
You do, and it's sunny today in Arizona too. It's beautiful. It's absolutely beautiful, and you've got plenty of windows. I don't want to ask you how much your heating bill is in the winter, but it is beautiful.
Oh, I heat with wood.
Well, again, thank you for coming on, Dr. Gantz. This was Dr. Bruce Gantz. He is he's a professor of otolaryngology and neurosurgery at University of Iowa, and as you can tell, been a wonderful researcher and a pioneer in cochlear implantation. Thanks for coming on.
Thanks, Mark. Have a good day.
Thanks for tuning in to the Listen Up podcast. We'll see you again next time, and be sure to click subscribe to get updates on future episodes.